Good morning and welcome to this week's episode of Ask Dr. Murphy. I hope everyone is doing well today. My name is Katie Berg. I'm a research study coordinator here with the Havey Institute, and I will be leading today's discussion. This will be our final episode before the holiday break. I'd like to welcome and introduce Dr. Robert Murphy. Dr. Murphy, how are you this morning?
I'm great, Katie. Thank you.
Excellent. Those of you who have been here before remember Dr. Robert Murphy as the Executive Director of the Havey Institute for Global Health and the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine. He answers your COVID, infectious disease, or public health questions each week on the Havey Institute for Global Health's Facebook page. Today, Dr. Murphy will be addressing the latest headlines and U.S. COVID statistics through today, December 21st. We invite you to submit any questions down below via Facebook at NU Institute for Global Health or by email at globalhealthinstitute@northwestern.edu. Starting with the COVID statistics for this week, average new hospitalizations per day were 3,347. The same week in 2022, we saw 4,990 hospitalizations. Average COVID deaths per day are 176. 1 year ago and this week, there were 370. And the new 2023 COVID vaccine uptake for adults is at 18.3%. For those 65 plus, 37.4%, and only 7.8% among children. Dr. Murphy, your reactions to those numbers?
They're up as predicted. Respiratory infection cases go up in December. They sprinkle through the fall, and then December they take off. Part of that in the United States is due to the Thanksgiving travel, but it's a Northern Hemisphere phenomenon. So they're up. They're way up. Over 3,300 new hospitalizations per day. We're getting close to what it was like in 2022, and 176 deaths. Not that long ago, we were well below 100 per day. So it's more than double. And remember, the death rate and hospitalization rate lag the infection rate, because you have to be sick for a while before you get hospitalized, and then hospitalized for a while before, unfortunately, some people will pass away. So those come later. Now, the unfortunate news is this new vaccine uptake. So there's a new vaccine as of September. It's specifically designed against Omicron, which is what's floating around now. Only 18.3% in adults and only 7.8% in children. This is really, really very low. And COVID is a more serious disease than flu. And as we're going to talk about actually later this morning, the flu vaccine uptake rate is much higher, almost twice as high. So this is all very unfortunate. And, some people they don't like the new technology of the vaccines. Well, Novavax makes a recombinant vaccine. That's the old-fashioned technology. So there is an option if you want to go that way, and they work the same. So please reconsider your vaccine uptake, and you should be taking COVID, flu, and if you're 60 years of age and older, RSV vaccine, which is a new vaccine that is just out this year for people 60 and over. So if you look I mentioned that the flu vaccine, the adults is 42.2% and 69.3% for people 65 and older. That's pretty good. Children for flu vaccine is 43%. This is 5 times greater than with the COVID. You will protect yourself if you take these vaccines. Nothing is perfect, but we're really just talking about reducing your risk for hospitalization and death, particularly if you're in one of those high-risk groups, which includes age.
Absolutely. And you touched on this a bit, but because we're not getting the, actual case numbers, those are no longer required to be reporting, we have been talking about, wastewater sampling a lot. And there was a new study from Belgium, actually, looking at wastewater that also kind of explained why we use wastewater as a tool to measure, infectivity or viral level. Can you break that down for us?
Yeah, no, the Belgians had a very nice study looking at wastewater. We do it here in the United States as well. We look in water, we can find viral particles in the wastewater, and we do. It's done around the United States. It's done really around the world, and kind of what they have found is that when they're analyzing these, they're looking back now in time through the prior pandemics, prior not pandemics, but the prior respiratory infection increase that we see December through March. Okay, and they screened samples and they looked at all the major pathogens. So influenza, that's a flu, RSV, human metapneumovirus, parainfluenza virus, adenovirus, bocavirus, enterovirus, rhinovirus, pericovirus, COVID, and then 4 of the endemic non-COVID coronaviruses. So basically the whole potpourri. And they looked and they found that the wastewater predicted, stayed up during the whole, winter season, and then, came down in the spring. So, okay, big surprise. No big surprise, but it shows you that we can predict when this increase in the seasonal viral infection period, when it begins and when it's going to end. So it's just another tool that we can use to figure out, how serious we need to be. And, especially in a country as large as the United States, or, look at the whole world, you can find areas where it's increasing and decreasing, and because everything is not the same. So it's just another signal that we have, because we don't know how many people are getting diagnosed because everything is over the counter now, and those are not counted. Nobody collects that data because you have it in your hand and there's no place to report it anyway. Everything is voluntary, and really nobody's collecting it. So we don't know how many cases there are. I can tell you there's a lot, because we get calls all the time. I have flu, I have influenza, I have COVID, because I tested myself. What will happen, and what is happening already, is that instead of just testing yourself for COVID with one test, you can test now with some of the new tests, COVID and flu together, which makes a lot of sense because there's treatment for COVID and for flu. You can take an oral treatment, and it doesn't matter whether you had a vaccine or not. And what will happen by the next season, not necessarily this respiratory season, but you'll be able to test for at least 4 things. So flu A and flu B, 2 different kinds of flu, COVID, and RSV. And it's likely to be on one little card, and you collect your sample and follow the directions, and you'll be testing yourself at home for all those things. Now, there's no treatment yet for RSV, but there will be at some particular point. As people know that they have these things, we can develop the treatments for them. Now, there is preventive treatment for kids under 1 year old or under 2 years old if they are high risk, the monoclonal antibody against RSV, which is in short supply. But so if somebody in a household had RSV and you had a young kid, you would want to definitely get them that monoclonal antibody. So there is sort of a treatment, but it's a preventive treatment, not a treatment. So anyway, that's what's happening, and everything's going to be over the counter now. So it's going to be up to people to test themselves and figure out how long they should be in isolation, should they be treated, and so forth. And so that's really what the future is going to bring, because these are potentially lethal infections.
Yes, and speaking about things coming soon in the future, there was a big announcement this week that the COVAX program is going to be winding down at the end of this year. Can you explain to us a little bit what COVAX is and then the impact that this will have?
Yeah, people in the United States probably are not too familiar with the COVAX program. It was a jointly led consortium by the WHO, the World Health Organization, which is based in Geneva, Switzerland. And it included Gavi, the Vaccine Alliance, UNICEF. I think everyone's heard of UNICEF. You know, the big groups that have something to do with vaccines, and it coordinated all of them. And it ended up distributing 2 billion doses of COVID vaccines, any kind of COVID vaccine they could get their hands on, to 146 quote economies, so groups, out there, and this is all in low and middle income countries. And the estimates are that because of COVAX, they averted 2.7 million deaths. I mean, that's phenomenal, a phenomenal worldwide public health effort. And that's just if they had the first two vaccines. Anyway, and so they ended up with in the low and middle income countries, 57% of the people got two doses of the COVID vaccine. And this was compared to 67% if you took all the rich countries and everything and combined it. So it's not too far off. But 2.7 million people, this is amazing. And so they got these countries got the vaccines through this COVAX program. COVAX will end, a natural ending, and the Gavi, the other vaccine initiative, global vaccine initiative, will pick up the distribution from here. So they don't need all three of them working together and pushing the vaccines out the door at this particular point. So it's kind of similar to what's happening here, where the emergency is over and everything is kind of back to, oh, by the way, you got to pay for your test now yourself, and and now you have to pay for the vaccine, and you have to pay for the RSV monoclonal antibody. You got to pay for everything. So good luck. But that is really the story. COVAX did a remarkable job and saved literally millions of lives.
Absolutely. And that, it's sad to see it come to an end, but it's really great the impact they were able to have while working. And this is a story that's been developing over the last few weeks here in the US and, globally in the North American area. There has been a salmonella outbreak linked to cantaloupes here in the US. Can you tell us about that and how many people it's affected?
Well, there's been 302 confirmed cases of salmonella in the United States due to contamination of pre-cut cantaloupe. So this resulted in 129 hospitalizations, including 4 deaths, 3 in Minnesota, 1 in Oregon. People in 42 states have been infected, and 5 people in Canada also have died as well. And this started October 16th, 2023, and up until the end of November. And the stickers on the contaminated ones said 4050. I don't know what that means. And product of Mexico, produit de Mexique. It's in French. And so it was a Mexican cantaloupe. And they were sold by a number of vendors. Quick Trip, Aldi, Vineyard, Kroger, and Sprouts. And they've all been recalled. And the recommendation is donate pre-cut cantaloupe if you don't know where they're from. And Malichita and Rudy brand cantaloupes also were used in this. So what's the deal with salmonella? So salmonella, it can be a mild infection, but it can be very dangerous in the elderly and children under 5 and those with any kind of compromised immune system. And a lot of the people that were sick here that ended up getting sick and diagnosed were resided in long-term care facilities and children attending daycare centers. So particularly with the pre-cut cantaloupe, I mean, frankly, this is a ridiculous phenomena anyway. Why you're going to let somebody else chop up your cantaloupe for you because you can't chop up the cantaloupe yourself. You can get the whole cantaloupe. It's even cheaper. But anyway, avoid pre-cut cantaloupe, maybe cantaloupe all together until this winds down. And it will be a relatively short period of time before this passes, because everyone knows now these are getting out of the circulation. They'll figure out where the infections were occurring and fix that problem. But right now, it's just avoid it.
Absolutely. Good advice. And we will keep an eye on that update over the holiday break. When we come back, if we're able to tell you that the recall has been cleared.
The Christmas holiday and New Year's without your friendly orange cantaloupe.
Oh no, what are we gonna do? But our next story, getting back into the flu vaccine, we mentioned this a little bit last week, but we didn't have time to get into the full article. This is a big story about a high-dose recombinant flu vaccine, a new formulation. Can you tell us about it?
Yeah. So the flu vaccine had been made in this egg-based product. They used like millions of eggs to make this. It's a very old technology. And, now with all this attention to vaccines, they're making this high-dose recombinant influenza vaccine called Flublok quadrivalent. And based on the amount of antibodies that were produced, which predicts the effectiveness, it appeared to be better than the standard flu vaccine. So this was an analysis of 1.6 million individuals aged 18 to 64. That's huge. That is like a big study. And so this ends up, the results, getting published in the New England Journal of Medicine, which is basically the top US journal. That shows you how important it is. And they confirmed influenza by PCR. That's a type polymerase chain reaction. That's like, kind of it's the best test, all right? It's not the over-the-counter one in most cases. And they found that in the recombinant group, vaccine group, there was 1,386 cases versus 2,435 in the standard vaccine group. Everything sort of kind of trended in the right direction. But the point is, it's no worse, and it might, maybe it's even better, but we'll see in the long run. The recombinant vaccine was the overall efficacy rate of preventing infection was relatively modest. Even when you do post hoc analysis and find the groups that did the best, it's ranging here somewhere between 15 and 20%. So we still got a long way to go with flu, but with COVID too, it's very difficult to prevent flu or COVID. And what you're really doing is preventing hospitalization and death. So right. The actual infection you're still getting. So, but anyway, again, you can save a lot of lives, particularly if you're in a high-risk group. If you take this new recombinant vaccine, or even take the old one. But it's just, this will be an easier manufacturing process. Probably it's going to be cheaper. And, it's a big step forward.
Mm-hmm. And I don't want people to get discouraged when they hear something between 15 and 20%, because the number of people that are getting the flu, globally or even in the US each year is hundreds of thousands to millions of people. And 15 to 20% of that larger number is a huge difference.
If like, what we say, like in the high risk group, 2/3 are vaccinated. That's a lot of people. So.
Mm-hmm. Mm-hmm. Next, another COVID study, this one out of Oxford Academics Clinical Infectious Diseases, showed data that roughly 40% of children are still infectious the day after their symptom resolution from COVID. Can you break down those findings for us?
Yeah, this is a very interesting story, well done study that published in Clinical Infectious Diseases, which is a highly respected group out of Oxford University Press, reported by the group in Minnesota. and they looked at viral dynamics in kids during the Omicron surge in Toronto. And they found that 40% of children were still infectious with COVID the day after their symptoms resolved. Kids get better. Kids get really sick and they look scary, you know, they're so sick. And then they just like bounce back and they all of a sudden they're running around and being normal. But a lot of them were still infectious. And they looked at this a little deeper and they found in some of these kids that the median time to symptom resolution was 6 days. 12% still had symptoms at day 10. And the median time to non-infectious viral load in the body fluids was 5 days after the symptom onset. So median is half. So half or more than that, okay? And it really said that 90% did not have infectious virus at day 10. And so what this is telling us here is that even in kids, we've got to still follow the 10-day rule. So you get sick, you wait till your symptoms go away. And the second 5 days, you know, you can have a little more activity. This is in adults primarily, but you know, you have to be careful for the full 10 days. And remember, the day you get sick is actually day 0, not day 1. So, and this data just backs that up considerably.
Mm-hmm.
It's 10 days, and you know, like this is going to have big implications in kids going back to school, because many of them are going to be infectious. So if you want to stop the whole thing, you either don't let them go back to school, or they've got to stay somewhat isolated and wear a mask, and you know, you got to deal with that.
Mm-hmm. Very large considerations to keep in mind as we keep living with COVID.
Yep.
But our next story is very interesting as well. Researchers were looking into long COVID and also long flu and comparing the two of them. Can you first break down what long flu is and tell us a little bit about the study?
Yeah, this is interesting study from the Veterans Administration, and they looked at 81,000 people admitted to a hospital for COVID and 11,000 admitted to the hospital with influenza. And they followed them for up to 18 months. You know, the VA has a very good electronic database system, and they can track their patients very well. And the patients hospitalized with COVID had an increased risk of death compared to those hospitalized for influenza. Now, we've known really for quite a while that COVID is more dangerous than influenza. So this is, again, just proving what we already knew in this very large database, this very large study with, you know, there's over 90,000 people in this study, and with very good record keeping. In the Veterans Administration, very few veterans actually go outside of that system. So they've got them, no matter what veteran hospital they go to, they've got the record. So it's a really, really valuable resource that we have with the veterans. And so what they found is that there's a lot of complications, you know, because they have the total record of the patient. And they followed, in this study, it's 18 months. They found all sorts of long-term problems that didn't exist before they had flu. Now, we know long COVID, you know, we know there's somewhere between 7 and 15%, or maybe even 30 or 40%, depending on what study you look at. And they're seeing the same kind of thing, but different problems with flu. And so what does this mean? Is they're bringing up the term here, long flu, long COVID, you know, probably long RSV too. I mean, so these viruses, these infections are having a significant downstream long-term effect in some people, not everybody, but some people. And a lot of it is cardiac problems, diabetes, cough, lung problems, hematologic outcomes, fatigue, mental health problems. I mean, all sorts of stuff. I mean, so a lot of it is traced back to the earlier viral infections. So it's a it is really going to open some minds thinking about, why do people get these chronic diseases later in life? Is it related to the infections you had earlier? We don't know. There was an article just this morning that from a Dutch study looking at people who had COVID and they got atrial fibrillation. That's an arrhythmia of the heart. And it can be very serious. And that was associated with poor outcomes and was associated with COVID. COVID triggered that more so than compared to what's happening in the general population. So it just is, these infections have more than just the infectious part of it, and then it goes away and there's nothing else happens. Apparently that is not the case for many people.
We will absolutely keep our eyes and ears out for more information about that. That was certainly the first I've heard of it, and I'm eager to learn more. So we will keep you informed. But the last story we're looking at today, again, we have touched on this previously, but dengue fever has been exploding this year globally. Can you tell us a little bit about dengue and its effects on the globe this year?
Yeah, dengue, again, Americans don't really think about dengue so much, but it's very common in the Caribbean. It's very common in the tropics, so Mexico, Central America, Northern South America. And those people have seen it. So about half the world's population is at somewhat risk for dengue. So dengue is caused by a mosquito that bites the person, gives them this infection, and they can get very sick. They get terrible headache, fever, massive fatigue, vomiting, a rash, and other symptoms. It's not a respiratory disease. And many people don't have any symptoms, but they get it. And we can tell because they develop antibodies against the dengue virus. So very severe cases can cause hemorrhagic fever and death. In other words, it's terrible. And in the first 11 months of the year, over 5 million cases of dengue have been reported from 80 different countries with 5,000 dengue-related deaths. Now, we don't have that much in the US. It's mostly people who are traveling to these areas. So a lot of people go to the Caribbean, a lot of people go to Mexico. Those are very common touristic destinations. But we talked about this once before, we even had 2 cases that were acquired in California this year. And a record-breaking 138 locally acquired cases reported in Florida. And that's way up. So what's happening here? Why is this happening? Well, this mosquito, very temperature sensitive, and as the temperature in the world rises and increases, we've had some record-breaking temperatures in the United States. This mosquito then can survive in these temperatures. So it's because of the global warming that the habitat for the mosquito has expanded. And that's why we're seeing these a little more here. So this is just a sign. We're probably missing many, many cases. These are just the people that actually get sick and go get diagnosed. So you can probably multiply these numbers by 10 or more, who knows? We don't know. But it's out there, and clinicians need to be warned about this, even if a person hasn't traveled. So especially if you're in the southern part of the United States where it is warmer, dengue is just, one of the differential diagnoses. No treatment as of yet, no vaccine as of yet, but that is likely to change in the maybe not near future, but ultimately. Dengue is one of the top priorities of the Drugs for Neglected Diseases initiative. And it hadn't been a big issue here in the United States. There was really kind of no interest because it's not causing, that much problem here. But now things are changing, and DNDI is what they call Drugs for Neglected Diseases Initiative. It will probably get some more support from the more northern countries in Europe and in the US and Canada.
Definitely much more on our radar than it was in previous years.
Right.
But on that note, I would like to thank you, Dr. Murphy, for your time, your expertise, breaking down the headlines, the statistics for us, all the big science words. We really appreciate it.
Well, it's never a dull moment here. So, but hope you have a very happy holiday, and we'll see you again next year.
Absolutely. We'll see you all in January. Thank you very much for watching. If you have any questions for the new year, please send them down below or to any of our social medias in the description. Thank you very much.
Happy New Year.